I think this was a perfect opportunity to talk about what some of the specific components are for health home services. And this will help us delve deeper into, okay, well, now we know what some of the service components look like. What will some of those actual hands-on care coordination activities look like as well? When we think of terms of care coordination or a health homes model, the two primary components are care management and care coordination. And there is a difference between the two, and we thought it was a perfect opportunity to depict that here in terms of what some of those general activities would look like. In terms of care management, there are activities that a care coordinator will provide on a very specific one-on-one basis with an individual. Making sure, if I'm the client, that I'm adhering to my medication management program, that I'm having my wellness checks that I'm supposed to have completed, and that I'm seeing my behavioral health provider, remember, core care, and that I'm seeing other medical providers, my PCP, to ensure that he or she is on top of or informed of what's going on the behavioral health side. So all of these activities will be managed or attended to on a very individual level for an individual. Now, if you can take it a higher level, part of the care coordinator's responsibility will be to care manage a population. Meaning if there is a subset of the clients or consumers that have bipolar disorder or schizophrenia, how is the care manager helping to assist the behavioral health providers or the PCP in caring for that particular subset of a population? So we're talking more in terms of aggregate data there. This goes back to some information that Don mentioned earlier. We want to do a better job when we're out talking about these new initiatives and making sure that everyone understands it's all a part of the Arkansas Payment Improvement Initiative. These are not separate components, but they all fit very well together, even in terms of what's going on the episode side. And when we're talking about episode, we're really talking about those specific direct care behavioral health services. And again, the care coordinator will be responsible for helping to support and facilitate the information sharing that needs to take place amongst all of the behavioral health providers. We've talked a bit about care plans and who would be responsible for what, and this is just a quick depiction. I think the most important key takeaway on this page is to show it's a constant interplay. The care coordinator really has a big responsibility in ensuring that all parties involved in rendering any kind of care, not just those who are healthcare providers in terms of medical services, but other community supports, everyone is informed as to what's going on with this particular individual. And again, if you'll think in terms of the higher level, how do you better care or manage a population that have common diagnoses or conditions? This is just another way that we have shown some general activities in terms of care management. And what we've done here, we've overlaid those CMS required service components to show some general health homes activities that would correlate with each of those. And again, we've parsed those out to show what would be done on an individual or one-on-one basis with a client or family in terms of what would be done health homes activity-wise on a broader population base. We thought this was a great opportunity as well. I know many of you know there's efforts taking place as we speak in the development of a patient-centered medical home. And there's a care coordination component that the primary care providers will be responsible for in terms of being the manager of medical services and coordinating and providing access to whatever medical services the individual would need. And we thought this was a perfect opportunity to just show again in general terms what the patient-centered medical home party would be responsible for versus the direct care behavioral health provider, and how the care coordinator would be responsible for pulling together all of those separate plans and into an integrated care plan.
You know, since you mentioned about patient care, medical home, you know, there's another concept of ACO, Accountable Care Organization. which is, is very much related to this. So has that been considered, or does that come into the equation in terms of, since it's very much related to the payment and all that? So.
It could be related in terms of how an ACO may manage a population, but that's the only commonality in terms of a health home. It's not a managed care program. And we want to make sure that's on one of those slides we mentioned, that it's not a managed care approach to providing care or being a gatekeeper. Really, one of the primary responsibilities of a care coordinator is to empower the individual to make the proper choices. So freedom of choice will still be protected, but it's not an ACO type model.
Okay. Can I have a follow-up question for Dr. Miller? Or?
Sure. He says no.
You mentioned about that one of the objectives is to make sure that we provide a quality and efficiency. And I was looking at the matrix that are used to measure quality and efficiency. I'm just a little bit concerned in terms of the indicators that are used to measure quality. Looks like it's more geared towards the efficiency, cost savings. But what I don't see, or maybe I'm missing something, is the quality part, because everything that's listed over here, having worked for NCQA, so I'm a little bit biased in terms of how I think about, process measures as opposed to outcome measures. So I didn't see any quality outcome measures that will actually assess that indeed the services that were provided were actually quality services. And also, what is the relationship between quality and efficiency? Because there's another measure that NCQA has called RRU, relative resource use, that you could provide good quality but be very inefficient. On the other hand, you could be both efficient and provide good quality. Has that relationship been looked at? I'm sorry, Dr. Miller.
So am I. Well, a couple of things. I'm going to turn it over to Betsy in a second, and I'm going to meet you outside later. But if you look back on page 8, look at the quality metrics. Do you see those? Okay. Those are some of the ones we're looking at. And I think we're also on the backside, we'll be looking at some other quality things, such as medication usages and which evidence-based practices they're using. Less process and more outcome to look at really what the outcomes of care really are. And that's going to be more on the backside, I think. But I'm going to turn it over to Betsy, who wanted to say it.
Hi, everyone. So actually, I would love to walk through these quality metrics because all of them relate to improving the quality of care and making sure that we're delivering care in a way that is evidence-based. So if we start with the percent of episodes with completed certification. So these certifications are both around providing a quality assessment, so making sure it's thorough, making sure it's looked at comorbidities, making sure it's looked for underlying things, in terms of learning impairments, language, or other things that could influence the ODD diagnosis. And so it ensures that we are, assessing these kids in a quality way. The second piece is with these certifications, they also speak to, am I including the family? Does the family know about the diagnosis? And also, are they going to be involved in care? So it's making sure that there is that family component, which is so critical to ODD and improving outcomes. The second piece in terms of the percent of episodes that do not qualify as guideline concordant care, this one goes directly to quality in terms of making sure that providers are using evidence-based treatments and evidence-based practices for treating these clients. The next one in terms of percent of episodes with greater than 9 visits, what we see in these treatments is that they typically span for 1 to 2 visits a week for the full duration. And so at the low end, that comes in around 12. At the high end, that comes in around 24. When we spoke with our clinical work group, they said, it is challenging to actually get the 12 because there are many reasons why clients don't come in. And so to give, more flexibility and a little more, realistic view in terms of what care actually looked like, we brought that down to 10. But the purpose here is to make sure that clients are receiving the right intensity treatment. Because what makes these programs effective is that you're getting seen, at least once a week for that 3-month period. And so if you draw it out, then that could potentially reduce outcomes. So that's something that we wanted to make sure we included. With the percent of new episodes with medication and percent of episodes with medication that are repeats, the purpose here is, we know with ODD that actually treatment should not have medication. And so what we wanted to allow for with the new episodes was that clients who were on medication, they had providers had the flexibility to then titrate these kids off of that and do that in a way that's safe, that accounts for, withdrawal symptoms, things like that. So a way that allows a period of time in which that happens. But then after that, once you've been seeing the client after that 3-month period, no client really should be on medication for ODD. That's what we've learned in the literature, and that's what we've heard from our clinical advisors. So that was a way to, make sure we can kind of improve medication practices in the system as well. And then the last actually is a true outcome-based measure. So the percent of episodes resulting in remission. In the literature, et cetera, we found, what the remission rates are for clients with ODD treatment programs. And so this metric then drives directly to how many clients then don't need a follow-on treatment program. So, have reduced their symptoms to the place that, they're not needing care anymore. And so with this, this one actually does move directly to outcomes.